Welcome to Sit and Stay, the podcast that breaks down the challenges of starting and maintaining a mental health practice into digestible chapters. Sit and Stay is presented by RipsyTech, an electronic health record company committed to addressing the mental health crisis in the United States.
Hey, Tom.
Parker, good to see you.
Good to see you. I feel like it has been a while.
I think you're correct because there was a vacation week and we delayed this a few days because we had a really nice sales call with someone. And
that's right. Yeah, actually, it's been like almost 2 weeks, two and a half weeks since we recorded.
That is possible. That is possible.
And the listeners at home would have no idea. And gosh, I think this is our 20th episode. Congratulations to us hitting 20 episodes already. And if everything has gone according to schedule, last week's episode should have been the guest episode we did with Julia Maestas. That was a fun conversation. People should go back and listen to that if they haven't checked it out already. Gosh. And that we recorded that like 4 weeks ago. Time flies.
Yeah, I think, the guest episodes and hearing people's stories about, why they enter this field and how they made a living at it and what they've been through are definitely always interesting. And I think helpful for anyone else who's starting out or been in this field to just get that perspective. So I've definitely enjoyed those. And for people watching the video on home, sorry about my massive e-bike in the background, but it was the
I'm not sure if you're recording on your OBS, I don't know what the
you're
GoPro
right
video maybe isn't picking that up, but
yeah, I think I blocked most of it. But yeah, if I jump this way you can see the back, but I realized that this office building doesn't actually have a great or even any bike rack to lock the bike to. So I'll have to figure something out because it's okay today since there's no patients coming in this afternoon, but in general that won't work.
Well, I should probably do a brief little intro here just to get the people acquainted. Welcome back to the Sit and Stay podcast, brought to you by RipsyTech. As already mentioned, I'm Parker, one of the hosts, product manager here at RipsyTech, joined by Tom, founder and CEO of RipsyTech. So let's get into it. This week is a continuation of the episode that we put out 2 weeks ago. So episode 18, which was all about implementing measurement-based care. We were not done talking about that topic. It's such a big topic. We wanted to do a second part. So that's what we're here to do. I would recommend going back and listening to the episode from 2 weeks ago first, because we're going to really just be continuing that conversation. We did a lot of laying the groundwork, defining what is measurement-based care. And now we're getting into some more specifics of different types of measures that providers can use, as well as talking about the practical, logistical aspects of incorporating this in just any practice, but really I think a group practice is where some of the more difficult challenges come up. So I'd say let's just dive right into it. And as I mentioned, we wanted to talk about, what are some of the most effective measures that providers seem to be using in measurement-based care for mental health practices.
Yeah. And I think, last time we went over some general items around questionnaires and measuring symptoms versus overall functioning versus patient problems. And I think this week we wanted to talk a little more specifically about, again, it's still on some level a subjective conversation, but I think I'll share specifics on how the past 17 years have evolved with my use and my clinic's use of questionnaires. And this would be a great episode to get some feedback on from other providers who do use questionnaires. Yeah. But we want to talk a little bit more on specific mental health questionnaires and how they fit into your practice. A reasonable place to start with this is if you look, there's a company called LifeStance. They're sort of one of the first mental health service companies that did an IPO, or initial public offering, and is a publicly traded company at this time. There's been a lot of interesting other issues with that company going public, and of course my mind just went to, there's a podcast episode in itself. But when when companies go public, you have to do a lot of pages of filings to go to the various government regulatory entities. And in those filings, LifeStance reports that they practice evidence-based care. And to support that, they said that they give the PHQ-9, which is, which was the main thing I wanted to say. And Parker, what do you know what the PHQ-9 is?
I do know the PHQ-9. I'm trying to recall the patient health questionnaire. I did Google that one. I'm not going to give full credit to my brain on that one, but I'm quite familiar with the PHQ-9. I believe you might have a few takes.
Yeah, why is the 9 there, Parker? Do you know the answer to
Well,
that?
yeah, the 9 is because it's a 9-item questionnaire. So
very good.
Any questionnaire with a number at the end is typically indicative of how many questions a patient needs to fill out. So PHQ-9, 9 questions, DAS-21, 21 questions.
Very good.
I have a master's degree in psychology.
Now, to step up the knowledge-based quizzing of Parker, how many, although whose master's degree is not in direct patient care or anything like that.
That's not, yeah. I come from a more research background.
The in our diagnosing of depression, Parker, how many different symptoms do we use?
Okay. That I do not know the answer to that. Maybe 5.
It may be a number we've already mentioned.
9.
There are 9.
Oh, okay.
Symptoms that we look at in depression, and essentially the PHQ-9 is taking the 9 symptoms that are written about in the DSM at the time 3, and then now 4, then 5, and sort of putting them in, how is your sleep been? Which, as our mental health clinicians, we're trained to ask about sleep, appetite, suicidal thoughts. And essentially the PHQ-9 is just taking those symptoms, asking patients to answer the questions with on a scale, and then using those measures and patient responses, they then validated and tested the questionnaires and came up with cutoffs for what might be considered depression.
Right. Okay.
And so the PHQ-9 to this day remains one of the most popular questionnaires for depression.
Mm-hmm.
It is a public domain questionnaire, which we'll talk about in a minute. The PHQ-9 is only validated for patients 18 and over. Despite that, it is often used in teenagers, and sometimes even younger kids. And I think this is the question, we deal with at Ripsy, Parker, because you and I are researchers who like to be by the book with some of what the research says. And so, the way we deal with this in our EHR is, if someone wants to give a questionnaire to a patient, we kind of block out those questionnaires that are not validated in that age range, but in keeping with flexibility. Yes. And knowing that sometimes it's important to bend or break the rules, we have a little checkbox if you want to see other questionnaires that are outside the age range. And PHQ-9 very commonly is used in adolescence. I think it's the sort of thing where probably the psychometric validity would hold up, and maybe it's even been tested
Yeah, I just did a quick Google search. There is a PHQ-9 modified for adolescents, typically called the PHQ-A, but I haven't seen the paper. I don't know how well the numbers hold up, so can't comment on that.
Gotcha. And then just to say the other so our top two diagnoses in mental health are depression and anxiety.
Right.
So PHQ-9 by far is probably the top measure of depressive symptoms, which is a patient report questionnaire. Do you know the anxiety one, Parker?
I do. It's the GAD-7. So are you telling me that there are 7 different parameters in which somebody diagnoses anxiety?
Now that is not true. And there's
Oh, okay.
multiple different anxiety diagnoses, whereas theoretically only quote one depression diagnosis. That is not really accurate, but the GAD-7 is definitely the most common one used for anxiety. Personally, I don't really like either of these questionnaires. I think I can't even say exactly what it is, but it probably has something to do with their reliance on phrases from the DSM in looking at the diagnoses, and that yeah, they feel almost too straightforward to me. I don't know how too simplistic. I don't know exactly how to
You mean
phrase
like
it.
not painting a full picture?
Yeah, or when you're using the symptoms that we use as clinicians to make the diagnosis, and you're just asking people, why I feel like we could do a little bit better with some of our questionnaires. And the questionnaire you mentioned, actually, the DAS-21, which is a revision of the original DAS, which has 45 questions, which stands
Right.
for Depression and Anxiety Stress Scale. I'm a big fan of that questionnaire.
I like that questionnaire a lot.
Yeah, and
Yeah.
I feel like it pulls in good, relevant questions that are hallmarks of diagnosing depression and anxiety, adds this kind of stress category, and has had very nice validation done, especially in young adults, which I think is, at least for the population I work with, more youthful. I really like the DAS-21.
Yeah.
Um,
So, well, I mean, I guess with all these different options, you mentioned, yeah, public domain questions. There's also license questionnaires. With all of the different types of possible diagnoses and then different questionnaires for each of those diagnoses, how should somebody go about assessing what the right measure for their practice should be?
yeah, no, great question. And let's go way back in time to 2006, when I'm opening up the first of my practices. And back at that time, we used to have and people will know this questionnaire. There's a psychologist whose last name is Achenbach,
Oh,
and
okay.
he had created what's called the Child Behavior Checklist questionnaire. And there was like 150 questions for the parents, and then a shorter version for the kids, which you can see that for those watching on video, you can see Parker's expression that that's just a little mean to maybe give that many questions. There's a teacher version as well. And on some level, it got to be known as a gold standard that you do these questions, it will give you scores in multiple different categories. And it actually printed out a very nice report you could give to your families. It gave out graphs. There was a follow-up version that was still a lot of questions, but again, gave you a very nice report. Here's where you were when you started, and here's where you are now. That questionnaire is not public domain. So that's a questionnaire that you need to pay a fee for and get the program to do the scoring. And that's totally fair and appropriate for someone who's developed and tested a questionnaire to do that. I think and it is a good, well-validated questionnaire. I actually like it a lot for what it does. I've shifted to the point where I would never give anyone that many questions to answer anymore for other reasons on validity. And
well, yeah, that was my big reaction. You said 150 items?
yeah, and it may have even been a little bit more than that.
Yeah, I mean, yeah, I'm typically, I mean, all survey questionnaire research, well, maybe not all, but I think, the reason that we come out with revisions like the DAS-21 is because 45 is already a high number. So of those 45 items, what are the 21 best ones for measuring depression, anxiety, stress, right? So yeah, you tell me 150 and it's like, in 2006, like, is there 18 years later, is there not like an 18 question version now? Or
it's actually a good question, and I wouldn't be surprised if there's a shorter version. I didn't do the Google search to see if there is at this time. If you think about, another famous questionnaire in mental health or psychology is the MMPI, the
Yep.
Minnesota Multiphasic Inventory, which is famous especially for diagnosing personality disorders. And that one, I think, tops 300 questions. And I don't believe that one has been reduced over time, but
Okay. I'm not as familiar with the survey fatigue when it comes to like a clinical questionnaire. A lot of my research came from a more like social psychological background, so we were always so focused on like, if you create a survey, keep it 5-10 minutes max, to keep participants focused, because we're measuring very specific things. I think maybe I don't know, because I just don't know I just don't have the experience of this, but I guess it makes some sense that you could do a longer questionnaire when it comes to like clinical symptom, because you might not have to think the item through as much because it specifically pertains to you, versus a social psychological survey would be, really trying to capture specific behavior or attitude in a specific moment. And you're going to lose that when it gets beyond 10 minutes, right? So that, I guess that makes sense, but also 300 sounds like a lot. I should be getting paid to fill that out.
Yeah, and and the truth is, Parker, also, sometimes as treatment goes along with patients, or especially adults, there is utility in sometimes throwing out some of these longer questionnaires. There's another questionnaire I like called the Personality Belief Questionnaire, which really kind of looks at the criteria for different personality disorders. It has 150-ish questions. It's not something you would give out on intake, but if you've been working with a patient for a while and there are questions of different personality traits, or you're getting deeper in a psychoanalytic or psychodynamic type of therapy, there is utility to a questionnaire like this. The specific questionnaire I mentioned, the Personality Belief Questionnaire, that one is actually one that is free for use by individual clinicians. It is, however, not one that we're able to put into our EHR without, and we haven't reached out. I don't know if it's something we should do at some point. That one would require negotiation of a fee in order to include in our
Like
EHR.
some kind of license fee, probably. Yeah.
Yeah. And then, so in addition, going way back in time, we used to give out that child behavior checklist. We would also give out the strength and difficulties questionnaire, which we will come back and talk about more, because we do still use that one today. For kids, we'd also give out this CDI, Children's Depression Inventory, which now has a sequel, the CDI-2. We'd give out the MASK questionnaire for anxiety, multidimensional anxiety scale for children, which also has a sequel, the MASK-2. And am I forgetting any? Well, we have my bullying questionnaire, which I validated, and that one is 20 quick questions that is the third graders can do easily. And
That is the
use-
PIPS, peer interactions in primary school questionnaire.
Very good, very good. And it's an easy one, and that one is free. That one is in the public domain and available to anyone to use. And it's been kind of cool. It's been used all over the world and translated and in other bullying studies. So that's fun to see.
I believe last year we went to a conference and I saw a poster about bullying and asked the person who wrote the poster, like, "Oh, are you familiar with the PIPs?" And they're like, "Oh yeah, that's a great question." I was like, "Well, my boss wrote it. He's right over there. You want to talk to him?" That's always
And
a
I
cool
think we talked about that on the last episode about, I developed that because there was no good self-report bullying questionnaire. And
Right.
yeah. And so, but I used to, bombard families with, I think the total was like 350 questions. And, it was because people are desperate for mental health care, especially for kids. We had very high compliance for parents completing the questionnaires. I mean, we had high compliance for the kids as well, though, again, as you mentioned with questionnaire fatigue, I don't know about how valid those questionnaires were. A nice thing about the child behavior checklist is they do ask the same questions maybe 3 or 4 times, and they give you a little score letting you know if people answered them the same way each time with slight wording differences. So you get this sort of validity check on the questionnaire.
I see.
Um,
I imagine that, and again, I don't know. This is just me theorizing. I imagine that there's perhaps a motivation component to a clinical questionnaire where if it's a patient that's motivated to want to learn more about themselves, then yeah, it's going to be more accurate. But then I spend a lot of time working with teens, giving questionnaires to teens, and certainly a teen who is not motivated for treatment, they'll see the questionnaire, and I think us researchers tend to call it bubble hell. Seeing all of the different and just hitting any random option and straight lining through all of the answers. But then a parent, a parent who cares about wanting to learn more about their child, they'll fill out the 300 questions if it gains some insight into what's going on.
correct.
I wanted to talk about like the training component, like with the staff. Is there anything that you want to comment on in terms of specific measures before we move to that?
Yeah, I think just the advice is for each clinic, depending on what you're treating, you should have a strategy to what questionnaires you're going to give out to patients. And it is important to get some measures. You can also get reimbursed for it,
Right.
as we mentioned on the last episode. But it is important to keep it not too burdensome, is where things have evolved over this time. So, for example, for adults, we really give 4 brief questionnaires that tend to cover different categories. We really like the strength and difficulties questionnaire, which is a free questionnaire if you're using it in your clinic. It is one that we have in our EHR, and we do pay the people who made the SDQ a very reasonable licensing fee to offer it for our Ripsy customers. And I really like just giving the SDQ and then leaving it up to after you see the patient. If there's another questionnaire that you need to give, then we have lots of other questionnaires for all the different diagnoses that you can pull out and send individually from the EHR. So we have LA trauma scale for people with PTSD. The one thing I go back and forth on is the SDQ does a nice measure looking at a few symptoms of ADHD, and then it is then we have the Vanderbilt questionnaire, to give
Mhm.
out to parents, and is another one that's really only validated for pre-high school ages,
Okay.
but is used often in high school. Whereas but then there's the SNAP 4, which is validated through high school ages. And just to
Yeah.
make another comment on free ADHD questionnaires that are well validated.
Yes. The SNAP is called, it's the Swanson, Nolan, and Pelham teacher and parent rating scale. SNAP.
Very good. And whenever, there is this very nerdy thing in statistics called shared method variance that whenever you only have one respondent giving answers, you're not completely getting accurate results as if you had 2 or 3 respondents. So when you're working with kids, if you have the same questionnaire appropriately modified for the kid, the parent, and teacher, getting all of that data is going to by far give you the most robust and accurate findings, which is helpful for for questionnaires that are subjective already.
So, well, I wanted to talk about, I don't know if we've mentioned this specifically, but those are, yeah, it sounds like these are all really great questionnaires to give somebody at the time of intake. What about questionnaires to give multiple times or at different follow-up intervals?
Yeah, it's another reason I like the SDQ, strength and difficulties questionnaire, because they have a specifically designed follow-up questionnaire that we have in the EHR that tracks well from the intake, and then to re-give that at every 3 or 6 month intervals. Vanderbilt, there are other questionnaires that have a specific follow-up version that you can give that often might save patients a few questions. In reality, re-giving an initial intake questionnaire, which PHQ-9s, there's no follow-up PHQ-9. So you're just
Right.
repeating the same questionnaire. And given where we're at in getting follow-up data, whatever works for you or is easiest.
I think the Vanderbilt has the Vanderbilt follow-up is shorter and it also includes some extra questions, but I think those are specifically in terms of like side effects for the maybe like ADHD medication or side effects of treatment. I'm not 100%. I just learned about this.
Yeah, I think there are fields asking for how treatment is going and any side effects or untoward effects of current treatment if your patient is taking medication for ADHD.
Well, so okay, so incorporating questionnaires, as you know, there's the follow up, there's there's the initial ones, there's the follow up, and then we're talking about making sure that patients don't have to feel overwhelmed every time that they fill out questionnaires. Um, I think where that becomes critically important is when you decide in the process of seeing a patient to give them that questionnaire. So, I wanted to transition into talking about, what do you recommend for, training or different resources for any staff that might need to know how to implement or utilize measurement-based care in a clinic. But then also, yeah, answering some of those questions about like, yeah, when is the right time based on the type of treatment that they might be getting or the age or what have you. So I just said a lot to unpack. Let's maybe focus first on staff training, or not even staff, but like it could be, you know, incorporating it in your small practice or group practice for the first time.
Yeah, so after the step of sort of figuring out which questionnaires you want to give at intake, and then the strategy for, are they going to do it on an iPad in your office, or are you going to text them a link ahead of time? Then it's this question of, and we've thought about this for years, right? When are you going to repeat the symptom questionnaires? I'm a big believer in, the little functional assessment for item. How are you doing? A monthly cadence is nice for that. But then The reality is for these longer questionnaires, even if they only take 15 minutes, I like a 6-month cadence. All of our research in mental health is built around 6 months of outcomes, whether it's
Right.
therapy sessions or medication trials. So I think for the purpose of not creating too much questionnaire burden or fatigue, saying that every 6 months, or if it's therapy, every 20 sessions would be a reasonable time to repeat a symptom questionnaire. I think if you're 3 months into treatment and things are maybe not going as hoped, by either looking at the monthly functional assessments or just by your work with the patient, that could be a good time to repeat questionnaires. So if you feel like the treatment isn't going well, I cut the 6 months to 3 months to repeat some questionnaires, because at that point, any guidance you can get on why things aren't going well is going to be helpful. But that's the cadence I recommend. So every 6 months, unless things are going very poorly, then maybe every 3 months to repeat the symptom questionnaires.
So what about say somebody's running a group practice and they don't currently use measurement-based care clinic-wide, and that person decides, hey, I want to implement measurement-based care clinic-wide. Um, what might be a smart tactic for beginning that process?
Yeah, I mean, well, the first piece is, you know, why have you decided to start implementing the practice? Because that's going to be the compelling story to your staff or to your clinic members about, you're creating more work. You're creating more work for yourself,
Right.
for anyone in your staff, for your patients. So what is the payout going to be from this extra work? And this is where having something where there's a very nice visual display of how patients are doing, or this is the information we're going to get, or, by doing this questionnaire, we're going to be getting a little more reimbursement from our insurance companies. Whatever reason you've decided to make the switch over to evidence-based care and start giving the questionnaires, that's what you're going to want to convey to your staff.
Let's see. I'm also thinking in terms of like if I'm a small practice and I want to incorporate measurement-based care for the first time, say it's just me. Are there any kind of like good resources for me to read? Any case studies that you know of?
Yeah, so there's a couple of really good articles out there. There is a great article as written by, and we can put the link up. But last name is Beidas, Beidas, in 2015. And it's called Free, Brief, and Validated. And it goes through all mental health measures. It talks about, are things good for assessment, for follow-up, for ongoing care, age ranges. And I really love this article. It's well written. And there is a follow-up to it in 2020. Beidas is still there as the senior author to that article. And I think it's called like Update to Free, Brief, and Validated. And both of those have great information on, if you're in your clinic and you don't want to go ahead and order a bunch of paid questionnaires, you can just download these questionnaires, and you can even, print them out and give them to your patients to fill out and then score them yourselves. And it's a nice way to get started with measurement-based care. I do think there's something to, the visual display of some of the graphical outcomes. And we have some nice tools in our product that after every intake, I'm sharing my screen, or in person or virtual, and showing people where they are on different graphs. And
Oh,
that's
that
that's a
sounds great.
nice conversation piece for planning treatment.
Yeah, it's so interesting to me to learn how not widely adopted measurement-based care is. Because, yeah, I think one of my first experiences seeing a therapist was when I was in my undergrad at college, and their center that they had you fill out an intake questionnaire on a computer, and then I filled out a follow up later, and I remember and this was like 2015 maybe, and I remember when my therapist had shown me like, hey, like here's where you were when you came in and here's where you are now. I was like, oh great, I didn't even know that you could do that. Good to know. Excellent. Good to see I'm doing good. And I don't know, I guess 9 years later, um, to know that this isn't the gold standard for all forms of treatment. I mean, I'm a numbers person, so I'm certainly biased, but yeah, it's been an interesting process to note that yeah, it's not an everybody thing. I think on that note, something that I hear a lot with different providers being concerned about, not even just with measurement based care, but also with like AI tools, is a concern over data and the security of that data. And I'm wondering, is data security or privacy concerns something that somebody should be worried about when implementing measurement based care? Is does does needing to be extra secure with like HIPAA related data affect how one might implement measurement based care in their practice?
Yeah, that it's a good question. And I think there's even been some, news stories about large entities with collecting kind of questionnaire data on physical and mental health symptoms, and then being in trouble for selling some of that information to
Oh,
advertisers. I think even Kaiser's maybe gotten in trouble a little bit for this, but you can see and Google may have been in trouble a little bit for this. So I think, though, in the context of a small practice or small group setting, or if you're using, as with anything, that if you're doing anything online, make sure you know what's happening to the data, and is it being repackaged and used for something
right.
else. um there's a big difference between looking at anonymous data versus data tied to people's demographics for targeted advertising and things like that. So on some level, the questionnaire data is less worrisome than, say, your insurance card info or other contents of your medical record, because often you're just putting an ID number or a first name and then filling in some different bubbles, as you mentioned. So there's maybe, it is conceivable that there's not even HIPAA protected information with respect to being able to identify who completed the questionnaire on the actual questionnaire. Uh,
Mm.
but data, yeah, right. Everything you do on a computer, especially, or are having your patients do, you want to be aware of what's happening with that information.
So it sounds like um, it sounds like if somebody had access to a patient's questionnaire data to the degree that they are able to look at that data and identify that it is the patient's data itself, then things have probably already gone seriously wrong with respects to all the other data that would be associated with that patient as well.
That is likely true. Yeah.
Yeah, which then makes me think about well, we like to go digital. Digital is great and makes things more efficient. But if you're doing this on pen and paper, um, using some kind of ID system would be a smart move. And if not, and yeah, they have to write down their name on the paper. I believe providers have like a special like two locks kind of rule or something. Like anything like that has to be, securely kept in a locked room, in a locked cabinet, something like that.
That is true. Yeah. Any patient notes or other patient information that has protected information needs to be the 2-lock rule, as you said. So a locked file cabinet within a locked office, if you're going to be keeping that paper.
Right.
Um,
All right. Well, we've talked about a lot. Kind of covered like a range of different things with measurement-based care. Is there anything else that you want to say before we move on to our mental health business moment?
Yeah, I mean, I think it's an area that, we're very interested in. I think, as you mentioned, it is not the number one EHR feature that people tend to ask about. So
Right.
we don't have the infiltration or just the interest around measurement-based care that I think you or I would like to see there. So we're super curious and interested to see, hear other people's thoughts. We heard a little bit at ACAP last year, and I'm sure we'll hear some more this year at the conference on, having people like, I don't care, I never use them and I never will, sort of
Right.
comment.
Yeah, that's always that. Yeah, that I had such an idea that this is like the biggest selling point of all time, and yeah, to learn that it's not is both a learning lesson, very humbling, I guess. But well, I think this really comes down to like somebody might not be bought into the idea, but then if they see the graphs, if they see how it could potentially help them, if they see just the information displayed in a very simple way, you know that would convince me. But again, I'm a uh, nerdier individual, so yeah, definitely save me here, Tom. I've got
Yeah, no, I mean, I think we're on this mission to help with in general, we're trying to make an easier, build a better machine. And we're trying to do that, and
right.
also trying to show, if we can make it as painless as possible for everyone involved and get these nice graphs, and it helps treatment and your patients get better, we'd love to see everyone do that. So that's what we're tasked with on the product design and technology side. And we'll keep pushing away on it. But anyone who has questions about it, or like to learn more about it, or just share why or why not they like measurement-based care, we'd love to hear from you.
Absolutely. Absolutely. Send those questions to sitandstay@ripsytech.com. Or if you're on YouTube right now, just leave us a comment. We'd be really interested to hear about that. It's always an interesting discussion to have. And it's actually one of the few discussions I can have about clinical care that I actually feel extremely well educated on, enough to have a firm opinion. Though, how to treat somebody with depression, I can't really have that conversation. But this, oh yeah, I'll have this conversation all day. Okay, awesome. Let's move on to the mental health business moment of the week. What do we got?
Yeah, I think I'll just kind of um, share some information. I think, as we've been working in our clinic to get a credit card on file for all of our patients, and that's standard now for new patients. But there was maybe 50 or so patients, maybe more than that we had to go back to and explain a new policy in our nonprofit clinic. And probably, about half of the people did it pretty quickly via an email or text message reminder. But then there was really a lot of people that didn't respond to the requests for a credit card on file. And, ultimately, there's a few weeks of kind of sending a couple more email reminders and text reminders. But then finally, I just picked up the phone and did some phone calls. And it was usually like a voicemail. People weren't usually answering. But the conversion rate from saying, hey, it's Dr. Tarshis calling, as you may or may not know, we now require credit card. There was sort of 100% success rate in the people who had not responded to email or text, in quickly responding and taking care of signing up with the credit card on file. And I think it was a reminder that even for those of us who, like, I like receiving text or emails more than a phone call, there is still something about, the person-to-person non-digital contact that can be powerful. And, to defend some of the people who weren't responding, sometimes filter email and text filters aren't perfect, and they can both go to spam containers when they're not spam. And there were definitely people that had been the case with the email and text reminders. So
what would you say the success metric was, percentage wise, for an email and text before you did the phone calls?
Yeah, well, and it would be we could actually run the actual numbers, but I'd say after 3 email/text reminders, we were probably up to 60% or so.
Okay.
But it was really, then one quick phone call, everyone took care of it within 24 hours.
Yeah. Well, that's really good news to hear that. Yeah, after one phone call, that does the trick. As we've been talking about, we're all about data here, and I am so interested in, looking at that. Let's say 60%, running those numbers. But then, when we go to implement some kind of solution that makes that a little bit easier for a provider, those are the kinds of numbers that I love to know, because then when we do implement some kind of solution, then we have a benchmark to base that off of, and try to get that, after implementing the X feature, we'll have 80%,
Right. And
So
I think that's why with
that.
things like our self-scheduling portal, we have a way for patients to do that, but then we also have a way for clinic staff to use the portal to schedule. And I think we know if you only use digital means, there is a fair chunk of the population that it's just not going to come to your clinic. So
Right. All right. Well, I think this is a great spot to end at. Let's go ahead and wrap things up. So I will say thank you for joining us for this week's episode of the Sit and Stay podcast, brought to you by RipsyTech. If you have questions, please, as mentioned, submit them to our email at sitandstay@ripsytech.com. Also, if you're interested in being a guest on the show, as we mentioned at the top of the episode, we loved having our guests on. If you're interested, let's start a conversation. Reach out to us again at sitandstay@ripsytech.com. All right, Tom.
Thanks, Parker.
I'll see you later.
Bye.
Bye.
Thank you for tuning in to this week's episode of the Sit and Stay podcast. Until we meet again, we invite you to sit and stay with the ideas and stories shared today. Dive deeper into how RipsyTech can support your practice by visiting us at ripsytech.com.